Thank you. So thank you, Ramakrishnan, and all the organizers, Dr. Jayantangada, Dr. Usha. We'll just, next 10 minutes, I'll quickly go through, I think it's an area which has already been discussed many a times, but we'll quickly have an overview on the deficient REMS. Quickly go through my agenda is over. What is exactly the definition? How do you define? How do you evaluate? And how you select the cases? So finally, that is it. And then a few techniques of any difficult ASDs which can be utilized in this also. So what do you define? The standard definition has been defect as deficient, rim as deficient is less than 5 millimeter. And absent, obviously, it is no rim or less than 1 millimeter is completely bald, as everybody knows. But there is a lot of limitation to that because you are not taking into consideration about the age, body weight, or body surface area. So since we have no correlation, it cannot be 5 millimeter in a 60-year-old man is called be deficient, but in a 5 millimeter in a 8 or 9 kilo kid, a 2-year-old, 3-year-old kid, I find it quite adequate for that. So it is because it may be difficult to categorize to each size and age, but it would be difficult. Another thing, different rims, the significance of deficiency varies. As you all know, aortic rim we don't consider deficient at all. Many a times we have an absent rim, completely bald aortic rims. We don't even bother about it. So I will consider a deficiency into other rims except the aortic rim. And the IVC and posterior rim 5 millimeter is acceptable, and even SVC is same number accepts. But into a mitral rim, I think I may not even take up somebody even just a 5 millimeter, 4 millimeter, because I think that the crux area, the heart moves a lot and the device is most unstable when you have a very small rim in the mitral. So I would even take as anything less than 7 or even 10 in adult as a deficiency in the case of a mitral rim. I probably want an input from other panelists at the last session or the end of the session. Then once you have seen imaging, how do you assess each rim? So it is again, it's transthoracic echo in almost everyone. In the younger kids up to 3 years or 4 years, when the transthoracic images are good, I don't go for a transesophageal echo. I can have a reasonably good imaging from the subcostal windows, which almost all the rims can be assessed very clearly. So I don't do a TE, even during intra procedure. If somebody is my colleague is there to give me a reasonable transthoracic echo images, I am happy with that. But many people electively do a TE for even smaller kids also. And if an adult patient, I invariably have a TE done for a pre-procedure and during intra-procedure. In the adult also, in the transthoracic echo helps to clearly define the mitral rim. So an apical four-chamber view is very good to assess the mitral rim. So even adults, please do a good, thorough transthoracic pictures also. And then comes to the rarer imaging modalities, the 3D and ICE. 3D, even though it gives you more perspective, even though the resolution is not as good as a 2D pictures. So it may especially more useful when there are more than one defect. Multiple defects, I find it, the 3-dimensional echo would be more beneficial. But when you're talking about a small, thin, small floppy rims, 3D may not give you that resolution. So again, you have to depend upon the 2D more often, especially in the case of deficient rims. ICE theoretically can give you better images. I've run a few cases in ICE, but then probably we are not so used to it. And then I'm not so used to the transthoracic transesophageal images. So in a difficult case, I almost invariably now depend upon the transesophageal images alone, because once it's expensive. And second thing, you need to have that ICE catheter. You need to have a 9 French sheath to put in the ICE catheter. So it is not very easy to useful in a pediatric age group, because I anyway have to take a 10 mm or 12 mm sheath in other side and don't want to use again another larger sheath on the left side. But adults, it can be useful. Then comes to which are the rims which are assessed in each. The transthoracic, as I said, the posterior may not be well assessed. Mitral rim and aortic rim can be reasonably assessed. But if you have subcostal windows, almost all rims can be very easily assessed in a transthoracic echo. Except for even almost all rims again can be more beautifully seen in transesophageal echo. The inferior posterior rims, we have that special maneuvers which helps you to more clearly define them. I think these are the pictures we have already known. We know exactly how the transthoracic pictures will give you the mitral rim. This is a regular deficient aortic rim. We don't usually now think about it at all. We almost always ignore that probably. because we are always sure about the aortic rim. You have a posterior rim which is deficient. In a 0 degree also, you can very clearly make out this deficient posterior rim. This is the retroflexion view which we had published long back, in which because of the near field clutter and then close proximity, you can, if you retroflex it, the image moves away from the transducer. So it tends to give you better evaluation of the posterior inferior rim. So it is quite useful when you are clearly evaluating the posterior inferior rim, because these are the rims which are more difficult to be assessed in any other views, neither transthoracic or transesophageal. And a few other factors are that in, in the case selection, next important thing is once you have seen a deficient rim, whether you need to go in or not. Basically also depends on the size of the device which you can implant on a specific kid or an adult. Age and weight do matter, because if as a thumb rule is that you don't exceed like 150 or 200% of the body weight. You have a 12-kilo kid, you don't put a device more than 16 or 18. But at many a times, I think we all broken the rule. We even put in a 24 into a 9-kilo kid. So, and the next question is the absolute size of the defect. So for the obvious reasons, the larger the defect, the more deficient the rims are likely, and the more less success you have happened. But then if you have a deficient rim, but overall defect size is not big, you are more likely to have a success, obviously, because we can more easily oversize the device. And the number of deficient is more different, obviously. The more the IVC rim and the aortic rim are deficient, then again, you are in trouble. You are less success. Septal length, almost all papers tend to mention that. I haven't measured it and I don't do it any time. So I don't know, but I don't really care about the septal length, but you go by the body weight. Another important thing which I think is very difficult to demonstrate and very difficult to profile it is the extent of the deficiency. You can say that the deficient rim is deficient, but at what point? Like here I just have a cartoon in which you can see a central defect, all the rims are good. But when you have a defect like this, it's an oval defect, so you have seen the deficiency is there may be 3 or 4 millimeter red arrow shows the deficient area. But in this area, the defect is oval and the deficiency in an angle of deficiency is quite small. You have a 20 or 30 degree in which you have the deficient rim, that may be 2 or 3 millimeter. But the same thing, if another defect, almost the size will be the same in the dimensions, but then you see the lot of area, like almost 30, 40, 50 degrees of area of the posterior inferior rim is deficient. So when you evaluate a patient, you do your complete transthoracic transesophageal echo, and this maybe 3D might be helpful to understand this better. You have to picturize the defect in yourself and then identify which are the places which are deficient. And then in the last cartoon, they're less likely to succeed. So this is a thing we need to keep in your mind while proceeding with the device closure. Obviously, in most of the deficient rims, you end up having to oversize it, even though there are concerns, heart block perforations are known. So you need to be careful when you're oversizing beyond a point. Again, which are deficiency always results in difficulty in deploying. So once you've decided to go ahead, you need to know how to deploy a difficult case in which different deployment methodologies should be utilized. The other thing is almost always better to be under general anesthesia, because something goes wrong, you need to have a good backup as though you can immediately move into the theater. Usually counsel the parents very clearly that this is a difficult case, I might embolize this, but then I have a surgeon standby. Something goes wrong, I don't try to retrieve it, because I know even if I retrieve it, I'm not going to put in a bigger device. So I usually, in those cases, I keep the surgeon ready, anesthetist theater ready, and then once I feel an embolization occurs, I immediately move into theater. I don't try to retrieve it. But we should be very much aware about the deployment techniques. It could be a rapid deployment, right upper pulmonary vein, trapping in the pulmonary vein, balloon-assisted mitral valve trapping, pushback. That all the methods should be aware, because it may vary depending on the type of deficiency. The basic principle all is that before the RA disc aligns to the septum, the LA disc resolution, the RA disc should come in place so that the LA disc doesn't slip out. It's a basic principle. I think here is a case in which is a left upper pulmonary approach. I think we all know about it. You get trapped in the pulmonary vein. Almost always everybody does it. Only thing, when you need to have that, the length of the device has to be quite long enough so that before the deployment, the enough length should be there from the septum to the pulmonary vein. So even if it's a deficient rim with a smaller defect, you may not try to approach this. So in those cases, you can move into the right upper pulmonary vein, because the defect size to the pulmonary vein is shorter in the right side. So instead of the left pulmonary vein, you can very well utilize the right upper pulmonary vein approach, except in the case of deficient SV. This is one of the easiest thing. Like initially Baradelvi has propagated this method. It is quite useful. You have a balloon assisted technique, especially in the aortic deficient rim, even in IVC deficient rim or a SVC rim. Almost all deficient rims is a almost a foolproof method, but you need 2 accesses. If it can be done by a single person also, but we're good to have another person helping you. So once you keep the balloon inflated so that the LA disc doesn't flip out, and then you deploy the RA disc and then keep it slightly pushed in and keep a subtle push while you deflate the balloon. And then because subtle, you tug on the cable will be important, because once you deflate the balloon and then pull back, there will be a small pull on the RA disc and on the partly on the LA disc. So you need to keep, you can see that cable is getting taut there. So that is quite important to do that. So you can go that to the next one. Here's another case. You can see, just give an example. The deficient posterior infraposterior rim, there's around 18 to 20 mm defect, and there's an additional aortic rim, the aortic defect, which is around 15-16 millimeters. So in this case, I went ahead and deployed the deficient rim. My concern was already the one rim is the multiple defects, and one defect is deficient IVC rim. So initially thought of putting both the devices together, but then I thought of a different idea of deploying one device first, and then if I am stable, so I can go back and do it the next device at a different setting. So I managed to get a reasonably 19 mm defect. I put in a 24 mm deployed device on the deficient IVC defect, and then went ahead later on, after a month, I went ahead and deployed another device on the superior defects. Usually can get away with the same sitting, but then here the deficiency, I didn't want better holding on the previous device so that it would be more safer to do it. This is the final position, the both device together. And before pre-release, you need to check the position. The rims are well caught, no residual flows, any encroachment of the adjacent structures, and stability. Minnesota wiggle is not a very good this one, but you can just see for stability. It may not always confirm it because it is just holding on to it. So it is not a foolproof method. Another method, as Shiva said, that you can hold with a snare. Once you at least don't release it, you don't temporize it, you can retrieve it. So to conclude, I think it's before starting on any cases with deficient rims, you should have at least good experience in doing routine ones. A careful pre-procedure assessment is important, and counsel the patients very well. Have a good surgical backup. Knowledge of different deployment methods is quite useful, and have a careful pre-release assessment. Thank you.